and you're ready to go.
Awesome. Thanks so much, Sean. I appreciate it. So, hi everyone. My name is Dr. Paul Bryan. Welcome to the Family Medicine Rapid Fire Reviews. I'm just trying to get set up here in terms of me seeing the chat so you guys can talk to us. Basically, as you guys have experienced and you've been doing this course for a few days, we're going to go through some review material, and I think you guys kind of have the hang of this. We're just trying to give you some tips and trying to make things as, sorry, I'm just getting set up here. Here we go. This is a bit better. Get you feeling prepared. So we'll just start without further ado. Amanda, do you want to introduce yourself quick?
Oh yeah, my name is Amanda Wang, and Paul and I graduated together, and we both like to teach, so we were asked to do the session for you guys, which we were happy to do. All right, let's get going.
All right, perfect.
Our next slide is disclosures. Neither of us have anything to disclose.
So basically what we're going to try and cover today is just some stuff that we commonly see in family medicine and that me and Amanda have a pretty good handle of. So we feel like we can answer your questions just around these topics as well. But really it's going to be focusing on the super high yield things. So like the common stuff that you see every single day, and that's what the test focuses on. So I've got some stuff listed here. And then you also have to recognize kind of really dangerous situations and how to manage those life-threatening ones, just the initial management. And then we'll do some of those common things that we see all the time, like I said, in family medicine. So rashes, MSK complaints, some psych stuff. And then we'll of course cover the preventative medicine stuff and go through some of those details that you guys know, some of those little tips and facts in those regards to help you answer those questions. So we're going to practice CDM questions. So this is the second part of your test on LMCC part 1. You have 38 cases on the test that you have to go through and about 70 questions. So on average, they give you about 2 questions per case. But there's cases that have 1 question. There's cases that have 5. About 3 minutes per question. So today we're going to practice those. We tried to make some hard ones, relatively challenging ones, and 17 ones. So that's about half of what you would do normally. And we're going to give you 90 seconds per question just to make it a little bit more difficult and give us more time to talk about topics if we would like to after. I want you guys to feel free to jump in with questions, especially in the chat, but even audio, feel free to cut us off before we get going down a tangent of something you guys already know or something that's not very helpful for you. Because you guys have been studying a little bit already, I'm sure, and kind of know best. We did this test 3 years ago, so we know a little bit about kind of what to expect as well, so we can try to answer some questions. We're going to use a Zoom survey, but we'll just use the chat. So as we're going through the questions, just let us know, is this something that, is really making you feel uncomfortable where your knowledge is at, or is this something that you feel good about and it's just reinforcing based on the case, and we can move on to the next one. We can focus more on cases and just try to get through all 17, and it'll just be like a practice case that we can discuss, the concepts around those cases and topics, or we can really just try and teach you guys and do more like a lecture style, and the cases will just be there to reinforce the knowledge. So we'll see how things go. We'll see if the cases are more fun, more valuable, or if it's more valuable just to hear us talk about certain things that you guys have questions about. So what are we going to do? So this is what things will look like. So we're going to review the challenging case. We're going to hear you guys' responses in the chat, like this doesn't make any sense, or yes, this is great, keep going. And then we have case topic review slides after each case on that topic. And it's just like the big key concepts that we think is a good framework to be thinking about these cases and these topics in. It doesn't have all the information because we can't teach you everything, but please do ask us about, hey, let's elaborate a little bit more on this point that you have in this slide. So we're going to go across the systems head to toe. We're going to cover a bunch of different systems. We're going to cover a bunch of different types of presentations. So we'll do head ones, and we'll go through the chest. Then we'll go through abdomen and GI problems, and then we'll go through extremity cases. So lots to cover, but we'll start getting through them. Few things just to go through. I'm going to go through this in detail today. Is basically just what to expect. Like, what do the cases look like? What are they trying to do to you in terms of the information that they give you? What are the types of questions that they'll ask commonly? And this can kind of help guide your study. And there's a few specific response rules that are good to know. They can help you avoid making, silly mistakes where you get points lost. In the end, you need to have just a broad, concise differential. This test is a lot about recognizing things, making a really concise differential that makes sense, ruling out some of those things in the differential that are dangerous. You know, it's really about picking up red flags. If you can recognize red flags and know what to do with them, you can do good on this test. And then just initial basic management. You know, they don't expect too much detail. You just have to pick the right drug, have to pick the right route, have to pick the right timing. It's pretty much it. You don't have to know doses. You don't have to know second line stuff too often. But yeah, we'll go through some of the cases and see and kind of show what's expected in all these regards. But feel free again to let me know if you guys have any questions about this. I would just go through this stuff later and make sure that this all makes sense to you. So without further ado, why don't we—
Paul, just before we get started, Paul and I created all of these cases. So these are what we think the right answers should be. And these are, from our experience, what we've seen the right answers are on the exam. But obviously there's room for argument and there's room for debate for certain things. So if you strongly disagree with any of the items on here, feel free to chat about it with us. But for the most part, these are what we think the right answers will typically be on the test.
Yeah, and we'll discuss it. And I think it's totally fair to discuss it, because even when you're writing the test, you know, we know you could discuss the test afterward. People have already written it, and it's very clear that there's some questions that just don't make much sense, and you don't necessarily agree with them. But that's the nature of the test. So even when I wrote these questions, I agree with you. I had some moments like that. So we'll let you guys read through this. We do have a question just from Emily about strategy. So why don't you guys start working through the question, and then I'll just talk about the strategy a little bit. So the strategy really is to put down and answer as many answers as you can that you think are correct, and be as specific as you can with those answers, and avoid things that are harmful. So if you think the answer is actually potentially wrong, and if it is wrong and be harmful, then you should consider avoiding putting that question, because you can get marks deducted from that. Basically, there's auto fails. You're going to learn about this as we go through. So the strategy you'll pick up, but that's just the general strategy. So we're going to answer this question as you get experience answering these practice CDM questions.
And then Maddie had the follow-up question. If you say select up to 6, but there's only actual 4 correct answers, if you choose 5, would you get 0? No, as long as you get the correct answer and you select up to 6. So for example, if there's only 1 correct answer, and they've told you select up to 6 and you've selected 5 or 6, that's totally fine as long as you get the correct answer and you don't select any of the auto-fail answers. If you select more than 6, you will get a 0 on that question.
All right. So we're going to answer some of these questions as we go through. So these are great questions. I would say still post them, but I might not answer them right away, because we're going to answer them as we review the answers to these questions. So I know we're going a little bit slower on this one because we're just discussing some strategy, but I'm going to get the stopwatch out, and I'm going to give you guys, 90 seconds in general, but we'll probably review this one in just about 30 seconds here if you're working on this. So maybe as you guys are just kind of making your selections here, we can start just kind of discussing this case a little bit. So I'll just read it out and tell you a little bit about what I'm thinking while I'm reading this question, and we'll see if that's helpful, and we can keep doing that. So this is a healthy 22-year-old. Sorry, I'm blocked off by like all my chats and everything. A healthy 22-year-old female who has a rash over her face, upper back, and chest. She's also got weight gain. There's multiple comedones and multiple tender dermal cysts diffusely over her face, upper back, and chest. There are multiple purple striae present over the abdomen. Blood pressure is elevated. Normal heart rate. She's been using topical retinoids and benzoyl peroxide consistently for 2 years, which effectively controlled her acne up until 8 months ago. So whenever you're thinking about this, so first of all, identifying what the problem is. This is acne. It's pretty easy to identify. It uses some buzzwords, uses a distribution that you can recognize. So we're in the acne domain, so I'm pulling out that topic in my brain. And then I'm thinking, for everything, okay, is this serious, right? Is this benign or serious? Well, it depends in acne if it's primary or secondary. So that's often another common question that you should ask yourself. So in this situation, it doesn't seem dangerous. She's stable, right? But there is a question of some other secondary etiologies. It doesn't seem just like primary acne based on some of the other things. So really, I have immediately a potential answer if they were to ask me, what's the next step in management? Well, one of the steps, especially what I'm thinking when I'm reading the STEM, is to rule out or exclude certain differential diagnosis by using tests. And the test will do this. It'll say questions, what's the next management steps? And that will include treatments, investigations, because that's real life, right? You have to make decisions about what's the next steps in terms of working up and investigating as well as treatment. Okay, so for this one, let's reveal the answers here. So the correct answers is a 24-hour urine cortisol, right? And so that's because we're ruling out the secondary cause of this acne with Cushingoid syndrome or Cushing's. And then secondly, what are we going to do for treatment of this person? That's the other piece of management. Well, they're not using topicals, or they have been using topicals, sorry, but they're not effective. So that means they need to step up and use the next line or the next effective treatment, which would be Accutane, PO isotretinoin. And whenever you use that, you want to worry about the teratogenicity. Okay. So hopefully that question made sense to you guys. Here's just a little quick slide on inflammatory acne. Remember identifying acne, like I said before, the first step. Remember what the differential looks like, right? So remember just some key features about some of these other things like rosacea, right? Like what's something specific about rosacea that would make me say this is for sure rosacea? Well, what about rhinophyma disease, right? Associated with rosacea. If they start describing someone who has like an enlarging, flesh-colored, large macular papular changes on their nose, I'd be like, that's rosacea, that's not acne, right? So just know those kind of classic buzzwords for these. And then understanding acne is just understanding the underlying pathophysiology, what it looks like, and then treating it with common topicals. First line is a topical retinoid. And if those don't work, then you can go to PO isotretinoin, and you do need to make sure that you do 2 barriers or 2 methods of contraception with that. So a question here, when you get 1 or 2 of those 3 answers right, do you get the question right, or do you need to get all 3? So you get the points relative to how many you get. So if you got 2 of those 3 correct, you would get 0.66 out of 1 full point for that question. Don't you need to test for lipids and LFTs before starting oral isotretinoin? Yes, you do, but it wasn't included in the responses. So the point isn't to get every single right answer, right? It's not a comprehensive list, but from what's available, what are the correct answers? If I accidentally put lipids or LFTs on there, I'm sorry, I meant to exclude them. And that's just a part of the test. You'll be like, I know what the right answer is, and then your answer isn't there. And what they're looking for is the other things that you would be doing that are included there. So that's what makes it tricky, right? So I think we learned a few things going through that one. So let's keep moving here. Let's go through case number 2.
Okay. So I'll let you guys read it, and then we'll go through it. We have about 3 minutes per case, so if we go very detailed, we might not get through our cases, but it's your preference, so you guys message us based on what you would rather do. I'll do this one a little bit quicker though. Yeah,
so I'll start a timer for 90 seconds. So go ahead and start this case.
Yeah.
So James, good question. Basically, the test doesn't care. It's a question on acne. And so for sure in real life, you might say, this seems like something secondary. Let's address the underlying problem. But in terms of the test, when it's asking you, what's the acne treatment for this patient? What's the management of their acne? It's going to be working up the differential diagnosis, right? Confirming that it is acne and that it's primary, or that if it's secondary, you're addressing the secondary thing and finding it. And then what do you do about the symptoms right now? So you would still treat it. Even in real life, I'd probably do that because they need relief from their acne. You would definitely still treat the underlying cause later down the road for sure. That's just not what the question is focusing on. Good point.
Then Corbin also asked about her blood pressure in clinic. Definitely. You do it at baseline before you start, and then when you do follow up with them.
Yeah, and you guys are totally right. The question could have been changed, but those were the right answers, right? And that's what you might see on the test. So the fact that you know more than what you need to for these questions just shows that you're preparing well.
Yeah. Okay. I'm going to go through the question stem briefly. So you've got a young guy with a progressive headache now daily for about 10 days. He's got a bit of a visual disturbance coming and going in his left lower visual field, self-resolving doesn't stay for very long, and his headaches are debilitating with associated nausea and sensitivity to light. He's taking a lot of medication, if you look at it, for his headaches. And his exam is normal and his vitals are normal. So what do you guys think the most likely diagnosis is? You can list up to 3, but for us, we had just the one key answer. And Paul, if you go next, it will tell you the answer is medication overuse headache.
All right. So when it comes to headaches, we have some slides here. It's really primary versus secondary. Again, you're going to, these are tips that you can tell your brain. Okay, what am I recognizing? What's the topic, right, with the diagnosis? What's the differential for this diagnosis? Is it primary? Is it secondary? Is it something benign? Is it something dangerous? What investigations would I typically do or need to do to work up this or confirm this diagnosis or exclude other diagnoses that seem likely as well? What is the first line treatment? If you have that, you're doing great. So headaches, I'm not going to bore you guys with this. 5, 4, 3, 2, 1, 0. 5 episodes of migraine, 4 hours to 3 days. 2 of the major criteria, which is SULT. I don't remember what they are off the top of my head. I'm not going to bore you with trying to remember. 1 of the minor criteria, and then 0 red flags, right? So what are the red flags? I have them listed here. You can go through a comprehensive history. If you recognize these buzzwords, these should make you think of red flags and should make you think of doing other investigations and not treating it like a primary headache. So when it's a secondary etiology, there's some basic investigations that you should always consider. Does it make sense to do this right now? So the test is going to ask you about ordering temporal or artery biopsies. And it's either going to be you don't need it, it's unnecessary, or you do need to recognize that you need to do that gold standard test for confirming giant cell arteritis. CT head, right? If you're worried about bleed, right? We go through some CT head stuff later as well. And then LP, why would you do an LP? Infection, high ICP, right? Make sure you do your CT before your LP to make sure you don't have mass effect and you cause a herniation when you do the LP. These are concepts that you'll need to think about when you're answering questions on the test, right? So treatment of primary headache, know the basics, right? Really, this is like no Tylenol, Advil, triptans. If they've tried Tylenol and that's it on the question stem, the answer might be NSAIDs. If they've tried both of those, the answer might be triptans, right? So just knowing the basic categories. I don't think you should know any, specific drug names for triptans or anything like that, right? You don't need to know those details. You just need to be able to recognize when to give them. And then remember, prophylactic therapy is an option as well. Okay, case number 3, let's keep moving. So I'll start 90 seconds. Let me know if you guys have any questions about headaches that you want to go back to, but let's do this next question, case number 3.
And we'll try and answer as many questions as we can in the chat to make things smoother and roll faster.
All right, so it's been 90 seconds. So if you're sweating, sorry, but we'll keep moving. Let us know if this is just insane in terms of timing. But so what we have here is a person who's having an episode NYD, right? Really, this is vertigo. People will describe vertigo in many different ways. It doesn't matter. Lightheadedness, dizziness, disequilibrium, room is spinning. Who cares? So what do you need to do for vertigo? You need to rule out a stroke, red flags. And then you also need to consider the etiology. So Hintz exam, Dix-Hallpike, right? So there's some red flags that are listed there, and then there's some typical vertigo exams that you have to do. So vertigo, the way I break it down, the way I teach it is to put it into different categories. So it's recurrent and episodic. And if that's the case, what's triggering it? Is it head movement, BPPV? Is it standing up, orthostasis, right? That'd be, orthostatic hypotension. Is it constant, right? So that means the vertigo is constant, unremitting, doesn't increase in intensity at any point. That's really concerning for a stroke, or vestibular neuritis, which is the benign form of that presentation. Most acute vertigos are benign, but 25% can be strokes when they do the research and look at them. So INS exam is the main thing to understand here. The other thing is these episodes can look quite similar. So it's really about picking up the differentiating features. So I just have a little cheat sheet here that you guys can go through later. And this just gives you those really big buzzwords of like what it looks like in terms of before the episode and risk factors, how they'll describe the episode and what their symptoms and signs will be after the episode for all these different things. These things will likely show up on your tests, and you'll have to differentiate them based on, the differentiating features. Basically, it's get a history. They're all going to be pukey, but the history again is triggers, and is it intermittent and episodic or constant? That's all you care about. And then you ask about these other associated features, which help lead you down a specific diagnosis. The big ones you need to know are the red flags that we talked about before, the deadly Ds. And there's just some examples of the deadly Ds. And then really what we want to see, or the most important thing to understand is the vestibular cochlear reflex, which is the head impulse test reflex. So this is testing it. Peripheral nerve reflex, just like a reflex on your patellar tendon. This is testing the reflex of the peripheral nerve of cranial nerve 8, right? So that's what we're doing with that. So this next one is basically a flow diagram of what you do clinically. And these are just the basic steps. So if this makes sense to you when you go through this later, you're doing great. And then the main thing to keep in mind is that the Dix-Hallpike is a little bit of a different pathway completely once you've ruled out a stroke, looking for BPPV, and there's just a little bit of a pathway on that. What are you looking for? So that's trying to rule out papilledema. You're trying to rule out increased intracranial pressure, right? So high ICP can make people puke, dizzy, especially if the high ICP is due to a stroke, a hemorrhage, a brain bleed, which increases your ICP, gives you a headache, right? Which could be the worst headache of your life, red flags. And will give you papilledema, will make you pukey, and can present with vertigo. So that's why you're looking for that papilledema. It would be abnormal to see papilledema in a peripheral cause of vertigo like BPPV or Meniere's disease. So that last question was Meniere's disease as well. So,
And then the way we organized step 2, by the way, is just the hints exam. And so you don't have to organize it the same way that we did, but we did cover and cover, which is your test of skew. And then we did the HITS exam after, but you can order it differently. It's basically just the 3 tests that you have to do together. And then there was a question, and I think it's good to review with the class as a whole. They said if they put one of the correct answers and then they also put CT head, would you get partial marks? And the answer is no, and that's something that you have to be very cautious of, because if you get ahead of yourself and you order a CT head right away, that's considered an auto fail, because if you look at resources and proper initial steps, that's not what you would do. Okay, so case 4.
So 90 seconds starts now. So go ahead and start reading this one, guys. If you guys feel comfortable putting answers in the chat, that'd be great. If you want to, could just give us a sense of how you guys are doing overall. If that bugs you and you don't want to cheat and see answers from other people, close the chat for now, but happy to have your answers in there if you want.
Okay, so we'll go through a review of case 4. Basically, you have a middle-aged woman presenting for a routine health exam who hasn't been to a doctor in a long time, and she's got some bilateral small volume nipple discharge, otherwise healthy and married and regular periods and uses condoms, and she's obviously very worried about this discharge and she wants screening updates. And so kind of you ask, well, what is indicated for her? And the correct answers, if Paul wants to reveal them, include A, blood pressure, B, pap smear, C, lipid panel, and D, A1C. And so those ones would be the autofill questions if you got sucked in to kind of the nipple discharge part of stuff. So if we go to the next slide, we look at your routine screening stuff. And the one caveat to all of this is you will not get tested on screening that is controversial. But basically, if you look at the history for her nipple discharge, it's very benign. But this is the slide that we made to kind of give you the differential on nipple discharge, because that's one of your objectives. So we go through the benign stuff and the hormonal stuff, the breast cancers, what to look out for, and then benign masses. So for the screening stuff, I don't think you'll be tested on lung cancer because that's a bit controversial. Same with prostate cancer. Cervical cancer is one where different provinces have different guidelines, but use Alberta guidelines for your test. So those as listed is how often and when we do our screening for different things. And then what's not on this list is kind of some of the other stuff that we did, which is routine like A1C checks, lipids, and blood pressure. And then some public health stuff at the bottom for screening principles, right? When we look at, when we do overscreen, we overdiagnose, and sometimes there's bias, etc. Paul, can you go back? Oh, no, never mind. Heather got it. And then the next slide. Okay, can we go back and show the autofills again, please?
Of course.
So low dose CT chest, that's one of the controversial kind of screening tests for lung cancer for smokers. Abdominal ultrasound for AAA, she's not in the right age or sex to do that screening. And then she's not in the right age group for FIT tests or screening mammograms or colonoscopy. And she doesn't need a diagnostic mammogram. Perfect. And then we'll go to the slide after this. And then that's just stuff for you to review on your own time. Basically, think about your different life stages when you get a test on screening. So remember things that are unique in kids, like hip dysplasia, amblyopia, your red flags, and always through every stage of life, screen for abuse. That's going to be something that I guarantee you will come up on your test. So just keep an eye out and have a low threshold for kind of looking at triggering that kind of stuff.
And just with one tip for responses with lifestyle stuff, diet and exercise can go together. They're considered one response. So Correct. If you know that diet and exercise is proven to be helpful with something and you think it's an answer to that question, you can just put them together as one response. So always think about things like that, like just really simple things like, you know, like counsel on wearing a seatbelt, counsel on wearing sunscreen, you know, insect repellent to avoid malaria. Like these are super simple health interventions that make a big difference. And they'll ask you about it on the test, and you just don't really think about it commonly. So just remember those things, read through here, make sure these make sense, make sure that they're kind of at the front of your head to be thinking about in sort of these more routine care, preventative care type questions. And then we just have some chronic disease management stuff too here, and we're not going to go through this in detail at all, but this breaks down the difference between primary, secondary, and tertiary prevention. And these are some of those public health concepts that you guys, or population health concepts that you guys need to know. So primary prevention before the disease occurs, trying to not have it develop. Secondary prevention, it's there. We try to find it as early as possible before symptoms arise and try to slow the progression and symptom progression. And then tertiary is symptoms are there. We cannot get rid of them. We're just trying to minimize symptom burden. It's basically like palliation. Okay, here's some immunization facts as well. These are just some basic things to know. Along with immunizations, this is a good opportunity just to bring up anaphylaxis. This is a medical emergency that will show up on your test. So know the basics, know how to recognize it, know what the differential includes, know what therapies you need to give. So really the main ones that you need to do is ABC management and give epinephrine, and then everything else is bonus or gravy, and it may be points on questions to know, but for sure the must knows are that epinephrine dose and the ABCs. Yep. Okay. Let me know if you guys have any specific questions about screening or anything like that, because we do a lot of it, so we can answer the nuanced questions as well. But otherwise, let's do the next question. So give you guys 90 seconds. All right. All right, so we have some answers from Alex, and those are the correct answers. So we'll show these answers. So basically, again, just when you're doing practice questions, do some simple kind of some simple challenges to yourself. Like, okay, so what does this guy have? Like, number one, making a diagnosis, right? That could be another question that they ask you for this case. So this is actinic keratosis that I'm describing here. Okay. What's the workup or differential? Well, that's a pre-malignant lesion, so you should definitely be considering malignancies and skin cancers. Family history does increase your risk, right? But sometimes they're only looking for certain answers. That would probably be a pretty reasonable one to have as the correct answer as well. You just didn't get points for it, unfortunately. And that's kind of realistic with the test, honestly. You get ones that are frustratingly included or frustratingly excluded. But if you would put family history in there as well, that's I think a totally correct answer. And you're thinking of the right things to be putting in answers like this. Like, think about the lifestyle things that are just common, like genetic, family history, personal history, right? That's a risk factor for like every single condition, right? Doesn't matter what it is: cancer, COPD exacerbation, heart failure exacerbation, gestational diabetes. Like, all of these are risk factors for getting the disease later on in life again. So it's totally correct. And then, you know, as I was saying, think of cancerous things. Well, then we'll be included in the workup. Well, biopsy may be an answer for some of these questions. They're talking about, you know, new skin lesions. So yeah, why don't we go through the approach a little bit? So basically, you have to know the common skin lesions. And really the biggest thing is, if it's a rash and it looks inflammatory, really strongly consider putting a topical steroid as a treatment option as an answer, especially if they're asking about management. It's super benign. It's commonly used. All these inflammatory rashes kind of respond to it, right? So here's what actinic keratosis looks like. You can also get actinic cheilitis on the lips as well. Sometimes that pops up. There's a weird sort of lip lesion that can happen. And then really you just got to think about, like, what are the things that help you differentiate these? So distribution is really a big one. Like, what's the stuff that happens in the armpits and the skin folds? That'd be like fungal infections, or like psoriasis happens. What happens in the scalp? Think of like psoriasis, again, for sure. Seborrheic dermatitis happens in the scalp. Discoid lupus happens in the scalp, right? Like, if you just think of those three things, you can think through, like, is this question lupus now that I think about that? Because maybe it was super confusing before, but once you think of lupus, you're like, this is lupus, right? So anyways, think about the distribution, think about the classic description, both in layman's terms and in technical terms. They may give you either or, and you have to kind of recognize it. And if you can get those buzzwords, you know what it is exactly right away. And also the associated features like itchiness or pain, right? So like, what are some painful rashes? Really, cellulitis is the big one, right? So if it's painful, you'd be like, this seems like cellulitis, or something really severe. That's sort of a red flag, honestly, for a rash, for it to be painful. So like Stephen Johnson's is painful. I think some vesiculobullous diseases are painful, etc. And then basically, you want to think about malignant lesions whenever someone's complaining about a new lesion. And you want to consider these three different types and the features of them. So actinic keratosis, again, about 1% per year convert to a squamous cell carcinoma. So know the differences of the features between those two. Basically, in the end, like, this one looks like a rash. This one is a lot more tumory, right? And so That's really what I think about it. But like, how would they describe that on a stem? That's what you guys have to think about. And then here's just the well-known sort of risk factors that you should think about for melanoma, and just have those on top of your head. That's all I would know about for these scheme changes. Okay, let's go to the next case.
Okay.
So I'll give you guys 90 seconds.
Yeah.
It's a bit of a longer case. We might give you a little bit more time for this one. We're doing okay with time so far. Let us know if you guys are feeling like, let's get through more cases. I think we'll be able to get through most based on our pace right now. Let's review a little bit more. So that's 90 seconds. I'll just kind of read through the stem a little bit in terms of what I'm thinking when I'm reading this. And that'll give you guys a little bit more time to select some answers. So 34-year-old male brought in with trauma, right? So immediately your mindset is trauma, which is such a different mindset than like, figuring out an internal medicine differential diagnosis problem, right? So according to people in the scene, is low speed. So it doesn't seem like a high risk, high energy trauma. He's fully conscious, had no loss of consciousness, so it doesn't have red flags that you should be thinking about. Was wearing their seatbelt, right? Think about seatbelts, like even in preventative case questions, you can put like counsel on seatbelt use. Self-extracted, so again, not that red flag. Patient is sitting up with a cervical collar, that's a positive sign. Complains of a headache, pain to his left arm where there's a laceration. So it's like, okay, he has a headache. Here's our first problem, actually. So he has a headache post-trauma. And then he has a laceration, post-trauma traumatic laceration as well. Primary survey is normal. So it's like, this patient is stable, it's telling me. Vitals are normal, stable. GCS is 15, no red flags, stable. C-spine doesn't seem that bad, right? No neuro deficits. It's just like really reassuring stuff. It doesn't seem like it's an open fracture because it doesn't seem like there's a fracture. It's just a laceration, it's just soft tissue. And then you want to think about tetanus, right? So what are the right answers here going through this zone or this mode of trauma that we're in for this patient? So we've used our CT and cervical head rules to rule out that he's going to need any imaging, right? So we can remove the cervical collar. We complete a secondary survey for look for other injuries, right? So when you're in trauma mode, you're thinking ABCs, right? And we'll go through this in the slide here in a second. And then you're thinking secondary injuries, and then how do we deal with those? This guy has a concussion and has a laceration. That's what you're managing here, but you've gone through the process still of a primary and a secondary survey. You always need to do that. So this case says 3 and there's 4 right answers. You just had to pick 3 of the 4 right answers. It didn't matter which 4, right? And questions will be like that. And you'll be sitting there and you're like, this one's right too though, and it'll bug you, but just leave it. If you're confident in your 3 answers, we move on to the next question.
And then sometimes there will only be, even though it says select up to 3, there will only be 1 actual correct answer. So,
yeah, and that's just the nature of the test. That's the black box that you guys don't know about, right? So we'll go over some things here, included some stuff. So here's basically the actions that are bolded that you can consider doing in a trauma case, right? So if they don't have a cardiac monitor on, it doesn't say clearly, and they're like in a major trauma, cardiac monitor, that's going to be an answer. 2 large bore IVs, that's going to be an answer. Oxygen, get vitals. Vital signs is 1 response. It's accepted as 1 response. So all these things are the things that you should be thinking about. And you could potentially say, like, if you're noticing a lot of bleeding, you should be saying like blood type and screen, serial CBCs, creatinine, You know, a tox screen you should be thinking about with altered LOC, all of these things, right? And then you should be thinking about potentially going to the OR stat with trauma, right? That's the one exception of you leaving wherever it is that you're managing this patient. So most times, like you're doing ACLS, ATLS type stuff, it'll be in like an emergency department setting. And it's always wrong to say to go somewhere else, because the best chance of that patient surviving and getting properly managed is in the emergency department, where you're giving them management as you see problems arise and as you see changes in their clinical status. Sending them to the CT scan is wrong. Trauma has one exception. That's if they have abdominal bleeding and injuries, and you think a laparotomy is going to save their life by stopping that bleeding. So always keep that in mind. Here's just different signs of traumatic brain injuries. Again, these are basically highlighted on the CT and cervical spine head rules. So go ahead and take a look at those. Those are super helpful, and just understand why those are signs that are dangerous. Here's the red flags as well. And this is part of your secondary survey. So once you go through A, B, and C's, stable, don't need to go to the OR. Okay, what's the other injuries that I may have not needed to address or may have not recognized yet? Because all you've recognized is how's their breathing doing, how's their airway doing, how's their circulation doing, but you haven't asked yourself, I wonder if this person is in a coma or brain dead, right? And so those are the things that you should be thinking about in the secondary survey. And the different options you can put down are the buzzwords you can see that should make you think of uncal herniation or coma and brain death to make that diagnosis. And then I think lastly here is just tetanus. So basically, it can get pretty complicated, and there's a few different graphs and everything, but if you just break it down as simple as possible, you need to get the immunization. So remember, immunization doesn't protect you in the moment. We're learning with this with COVID. It takes time to develop. So if someone has a cut, right, and you're giving them the immunization, you're not worried about them getting tetanus then. You're protecting them for the future. So really, the main things to keep in mind is just these simple criteria. And then basically the rule is if it's clean, if they haven't had their primary series, which is 3 doses, right? So that's why 3 doses is sort of an important cutoff. So if they haven't had their primary series, or you don't know if they've had their primary series, you should just give it to them. Or if it's been more than 10 years since their last dose, whether it be a booster or their last primary series dose, it's been too long, you need to boost them up to give them more protection. And then if it's anything that's not clean and it's been more than 5 years, or if it's not clean, then just basically that cutoff shortens for only 5 years since the last dose. And then the immunoglobulin is what protects you from tetanus with the injury. So that means they're missing their primary series. If you have your primary series, it's extremely unlikely that you get tetanus. So you don't even really need to worry about the immunoglobulin. So they don't have their primary series, or you don't know that they have it. Plus, it's risky, it's not clean, it's a bite wound, it's got dirt in it, it's a puncture wound from a dirty nail, basically anything but I was washing a knife in my kitchen sink as I was cleaning it. So why is secondary closure of the laceration an automatic fail? Because it's not standard of care. Standard of care would be to do primary closure. There's no contraindication to do primary closure for this one. So again, primary closure contraindications would be greater than 24 hours or high infection risk. Okay, let's move on to the next case.
Okay,
Just
time.
answer this question, Alex, as well. So is it safe to remove the C-collar? So good question. I may have messed up the case, but how can you answer the question? Go to the C-spine rules. What do the C-spine rules tell you, right? Those are your guide when you're unsure. So based on the C-spine rules, if they met criteria for it, I don't really care about those specific details of like, a motor exam. In real life, yes, you do like a screening motor exam and stuff, but on this test, it's not going to give you complete information. It's only going to give you partial information. So if it's missing something that's like #1 thing on the C-spine rules, that might be the answer that they're looking for. But if it gives you like the major criteria for the C-spine rules are negative, that's trying to basically tell you like this person is low risk, you can remove their C-collar. But yeah, I agree with you. I think it's a little bit of a debatable answer.
Yeah, I'm not sure that they'll test you on C-spine. James is right, as a resident, you can't remove the C-spine collar, only staff can clear. But on the exam, if you were asked, you pretend you're staff. And yes, there are rules and guidelines for C-spine X-ray to clear the C-spine. I'm not sure that you guys will have to know the exact X-ray findings, but there are rules. You can look them up.
And I think this brings up a good point is with this test, especially with you studying, you have to ask yourself, do I want to get, because there's about 90% of questions where basically it'll just spell it out for you. It'll say the 2 or 3 big red flags. And if you recognize them, you recognize them. And then there'll be about 10 to 20% questions that are difficult. They're really nuanced. And those are the ones we picked here to do with you, right? So we picked the hardest ones. We try to make them very challenging. And so you have to ask yourself, do I want to get lost in the nitty-gritty details and study extremely, specifically to get those details, to get those 10% right? Or do I want to know like the big and obvious things of like, this is a bad thing for C-spine. This is a bad thing for a brain injury and needs a CT head. I would focus more on just like knowing those big red flag things, and knowing the C-spine rules includes those big red flags, but don't get lost in like, the subtext of the C-spine rules that are like 5 paragraphs long and talking about like the limitations of the study and all this stuff. Who cares? You can learn that stuff clinically, not for this test.
Okay, are we ready to go over Q7?
It's been about 90 seconds.
Yeah, I think so. So basically you have a 78-year-old female with a slightly low MoCA score of 21/30. She's got no one who lives with her, and she's been noticing memory problems for a few years now, and her kid is now doing her banking, and she's no longer cooking for herself nor shopping for herself, and she's got a bit of urinary incontinence, but she has fecal continence, and she's slightly constipated. She drives herself still and is otherwise independent, and then it's got some background medical history of hypothyroidism and right. So what investigations would you order for this patient? And you can list up to 5, and if you click next, Paul, that shows kind of what we had here. Basically, in cases like this where you have some cognitive changes and decline, you need to rule out other causes, right? And so commonly in elderly people, you're going to want your TSH, even if she's well controlled on Synthroid. If you haven't had a TSH in a while, you need to be checking. And other things like calcium and vitamin B12 are common ones. And then syphilis is a very uncommon one, but one you should always be thinking about. Obviously, if in the case stem, there's predisposing factors to somebody for being high risk for syphilis, that would make you think more highly of it. And then a CT head for her also.
Yeah, so you guys have some good questions here. So you guys are thinking about the right things, but really what this question is focusing on is what is the workup for dementia? So in this case, what I'm thinking, this is quite clearly dementia, and it's not what the differential is. So what would be the differential? The differential is delirium and depression, as well as some other things that you should keep in mind, like normal pressure hydrocephalus, hypercalcemia, but those are really quite rare, and they'd have to have those distinct features that make you think those things, which this patient does have some of those. So when you guys are talking about electrolytes, urinalysis, really what you're getting at is like a delirium workup, like do they have an infection that's causing this? But this patient doesn't have delirium features, they have dementia. So what are the other differentials that I talked about that could actually apply to this patient more appropriately? Well, they have urinary incontinence. So NPH is triad of abnormal gait, urinary incontinence, and cognitive changes. So definitely a CT head to look for NPH. That's why this is specifically included and not those other delirium things, right? So I've excluded those delirium things on purpose. So those would be answers that I don't think deserve points, honestly, unfortunately, but you're thinking the right things. So I can reassure you there. And then you're thinking, what are some other things here? She's constipated, so hypercalcemia, so you want to rule that out. That's why that's included. And then no matter what, based on the objectives, you got to consider a syphilis, a B12, and a TSH for any new diagnosis dementia. For those 3, those are going to be included no matter what other features are present or not, because thyroid disease may have no other features. Syphilis may have no other features. Vitamin B12 may have no other features, so you just have to test those things. So those things are for sure right. The other 2 were based on this specific clinical case, but you're right, a clinical case where it says she's also been complaining of dysuria and she's maybe has some fevers and chills, and it's more of a short fluctuating course of cognitive changes, then you're thinking delirium workup. Then the right answers are all those things, like, let's get a CBC, let's get blood cultures, get urinalysis, let's get chest x-ray, all of these things, right? So that's awesome. Okay, you guys are on the right. So this is again, definition. So you're thinking of cognitive impairment. This person has a MoCA, defining the cognitive impairment. They have IADL and some ADL impairment. Here's the different types. And then your big differential, delirium. Recognize the features of delirium that are different. driving assessment is a reasonable answer for sure. And that's something that they could have asked you as well. But it's not an investigation. So it wasn't asked. It asked what investigations are you including for the workup? And driving assessment isn't. That's an assessment. But if it asks what's the management and driving assessment was listed or it was fill in the blank, I think driving assessment would 100% be a right answer to put on that question. I agree. Sorry, I just can't see part of my slide here. So depression is, again, screen for that always and think about those features. And then here's delirium. Here's the different risk factors that you can see coming up. And basically get hyperactive or hypoactive. Yeah, it's an important thing to recognize because it causes mortality. The other thing with elderly people is just frailty and falls. So this is a good thing to kind of be aware of and go through and understand some basic answers that you might be able to get for someone who has a fracture or a risk of fracture, which would be basically they're falling and they've got brittle bones, so osteoporosis. So before, remember we talked about osteoporosis, BMD screening at 65 plus or high risk things like taking prednisone long term. So yeah, so here's just some basic things that you might recognize for when someone says they're falling or they're having abnormalities on their get up and go exam. So like their balance and their posture, they're frail. So, they're low weight, vulnerable, all these things. And then you can do vitamin D and calcium exercise program, home care assessment. Right? Think about medications that be contributing. Would be a classic medication like antihypertensives. Right? If they're complaining of like orthostatic symptoms and it's like a falls question, the answer might be stop their antihypertensives. When typing answers, should we avoid electrolytes or what should we use? Assume that includes question mark, should we typing out? So you can look at the rules and the response rules that I have on the first thing and it tells you exactly what can be included as one response. Electrolytes is one response. And extended electrolytes is not a response, I believe. I think you have to individually put calcium, magnesium separately.
Yeah, you have to write them out, I believe.
And then, yeah, know your ADLs and INDLs, how to recognize when those are impaired, how to ask about them. You may have to ask about them as responses. Okay. Okay, so basically, don't forget that dementia, probably the treatments that you guys actually probably need to actually study and know is like all the soft stuff, like the advanced care planning and like the social support stuff. And it's just honestly, like you're just going to have to put these as answers probably and kind of understand the nuances around them a little bit. Like what does an advanced directive versus a will or enduring power of attorney do? What's the components of capacity? What's the components of informed consent, things like that. And then there's just some basic features of the different types of dementia that I've listed here, which allows you to recognize, what type of dementia it may be and specific features that make you think of dementia. And it's important to recognize these because if they're describing a dementia case, then all of a sudden they talk about some of these associated features that may confuse you about what's going on, especially with Lewy body. You may be thinking this is more delirium with like some hypnagogic or hypnopompic hallucinations. So that's important to keep in mind. Okay, let's move on to the next case. So I think we're doing pretty good with time here. We're just under halfway and we've spent about 50 minutes, 40 minutes going through cases. So we're doing fine with time. So we'll kind of keep on this pace. Let's do 90 seconds to try and get through this case.
Oh, and then there was this question about CT versus MR brain. And is it because that CT is faster to organize? And I think that's partly the correct answer.
So yeah, and I wouldn't worry about like resource. Like that's not part of your thought process in this test. It's what am I looking for? Is an MRI indicated or is a CT indicated? If you don't know, then we can go through the MRI and CT indications, and it does come up actually a little bit later when we start going through some of these things. But a CT sees big and bad things. It sees a brain tumor. It sees a bleed like a subdural hematoma or intracranial hemorrhage. It sees an acute stroke, right? Even an ischemic stroke. So those are the things. It's like someone comes in acutely and it's like, we just need to figure out if big badness is going on and what it is. So that'd be like red flags of a headache, red flags of a trauma with TBI and CT head rules. Those are CT. MRI, why would you do an MRI? Well, there's a couple ones for sure where an MRI is more helpful than a CT, looking for multiple sclerosis for sure, right? That's the time you're going to put MRI when you're thinking MS. What's another MRI? In vertigo, if you think it's a stroke in vertigo, an MRI is usually indicated because an MRI is sensitive enough to pick up the small brainstem strokes. So that'd be another example. Would it be wrong to say CT head? I think it's debatable. I would honestly probably put MRI on the test, but I don't think it'll come up. Really, the big one is thinking about like MS, things like that that wouldn't show up on a CT scan. CT scan is more often going to be the right answer. Okay, so it's been about 90 seconds. So we have this gentleman here. So he has a chronic cough. It's been going on for a while. So really it's thinking about what could be the cause and what do we need to do in terms of potential workup to rule out badness, right? So that includes doing a PFT. He could have COPD as a smoker. Could be a chest X-ray. He could have just a massive lung mass that's causing a big chronic cough, and he's got a lung tumor and cancer. And then he has GERD. So let's give him some symptomatic treatment, right? So what makes you think of these answers is going through this approach. So acute cough, think about infections. And there's some big ones that you guys should kind of know and know the kind of a little bit of the nuanced basic details of. So with certain viral ones, remember, do not prescribe antibiotics. They're going to try and lure you into inappropriately prescribing antibiotics on the test, but they're also going to ask you to prescribe antibiotics on the test. So you got to pay attention. If it's viral sounding, then don't do it. I think we all have some familiarity with what a viral illness looks like with COVID recently. But remember that there's specific phenotypes, like in kids, croup from metapneumo, I think. And what's the treatment for that, right? Mononucleosis, what are the features of that? Splenomegaly, more chronic fatigue, right? It's usually a younger person. What's the test for it? Monospot, right? Knowing those basics is important. And then, basically, if you're thinking of a bacterial infection, you got to do a chest X-ray, but you don't need to do it for a viral, right? So there's some big differentiators between there. And then the chronic cough, one that we're going to, group A strep, just to talk a little bit, like no Centor's criteria. If it's a very obvious, they are a check mark for all Centor criteria, you can just empirically treat. But generally speaking, it's not wrong to do a throat swab when you're considering this and just know the features of Centor criteria that make you think of group A strep. Remember, they usually don't have a cough. And then the chronic cough differential, which is postnasal drip, so coming from up top, coming from down bottom, which is reflux, or the lungs themselves. And remember, there's like benign things like asthma. What are the features of asthma that make you worried about that? Like it's nocturnal, right? It's got a wheeze. They've got other atopy like eczema, allergic rhinitis. And then don't forget about lung cancer and the red flags around that. If you notice those, you need to do a CT chest, not a chest X-ray, right? A diagnostic test for cancer when you're quite suspicious of it. You need to do a CT chest, not a chest X-ray. That's not diagnostic for cancer, but it's a good screening test for something like, say, chronic cough, where you just want to rule out cancer and there's not very many features of it. It's just someone who's potentially at risk. You want to make sure that there's not something structurally going on, right? So it's a bit of a different question you're asking. Okay. Yes, the chest X-ray is due to the wheeze, so chest findings, right? You want to make sure that this isn't, some sort of consolidation or something that's changing structurally the lungs. So ruling out a lung cancer, ruling out, an organizing pneumonia that would show changes on a chest X-ray. All of these things are reasonable things to consider, but basically it's if they have symptoms and they have a chronic cough, you should probably do a chest X-ray. Okay.
Oh, can you go back to the autofill?
Yeah, of course.
From number 8. Basically, if you inappropriately jump the gun and treat with antibiotics or steroids, that would be very, very incorrect.
Mm-hmm. Yeah, like for this guy, like could you do inhaled corticosteroids and treat them empirically as asthma? You could, but you wouldn't give them PO steroids, unlikely, unless you think it's an acute exacerbation and clinically it fits, right? So when do you consider a post-viral cough no longer just that and it becomes a chronic cough that needs investigation? You'll get different answers from everyone, but the longer it goes on, for sure, the more suspicious, the more likely it's to become a chronic cough. The technical cutoffs, I think, is kind of like 4 to 8 weeks for cough for most things. The average viral cough does last for 3 weeks. So if you get on the bad end of that, it can last much longer. So it's just basically you're thinking of the right differential, and it's going to be the specific features that you're thinking about. Chronic cough can start and be triggered by a viral illness for sure. All right, let's go to the next case. So give you guys 90 seconds.
Oh, Paul, go back. Your answers are on the screen.
Oh. My apologies.
Okay, that is time. So we'll go over this case. You've got a 62-year-old male. He's drowned and he's now presenting to emerge. And you know, he was unresponsive and he was intubated at the scene. His vitals, he's got low BP, his heart rate is low. And you think, hey, maybe his heart rate's inappropriately low for how low his BP is. His temp is normal, he's sounding okay, but he's on 5 liters by bag. And there's an ECG from the ambulance that's available below. I don't know if you guys can see that really well. And I don't know if maybe it's possible for us to zoom in or not. But continuing, what's interesting is he's now in emerge and first responders are performing chest compressions. And so you're like, well, what happened between him just needing to be bagged and needing chest compressions? And so they say that, hey, he was yelling for help before he essentially drowned. And then this is the ABG that we have for you. And then those are some of his initial labs. So basically, what do you include on your initial management of this patient? Select up to 6. And if you look in detail, if you look in detail at the ECG, he's having STEMI. And so first of all, go back to basics. You start and you go through your ATLS kind of protocol and ACLS. You obviously want to be checking for pulse because they're doing chest compressions, and apply cardiac monitor in your pads to prepare if you need to defibrillate. And as part of your ACLS protocol, you continue chest compressions until ROSC, and then you continue bagging at 6 to 8 breaths per minute. The other one is you can catheterize both to check for like urine output and to get initial urinalysis because you're like, well, why did this guy drown? And you see if you can pick anything up on the urine. And classic start 2 large bore IVs. And then you'd obviously also want to activate your code blue protocol, right? One of the big things on the test is knowing when you need to call for help. So calling for help is important. And then thrombolytic or TPA IV, given his ECG findings and clinically how he's presenting as an unstable patient, you cannot send him to the cath lab. And then you also want to check your tube and whether it's working, and then complete your secondary survey. So there's a lot going on in here. And this goes through a lot of the kind of emergency management of cases. So if we go to the next slide, Paul and I created some stuff for you guys to go through. So this actually was from Dr. Cito, who you guys probably have all met. And it's just a 1-pager that goes through your different ACLS algorithms. Feel free to take time and go through them because this is something that likely you should relatively know for the exam. So when you have different rhythms and what to do for them, whether you're bradycardic or tachycardic, and whether you have no pulse at all. And then those are some of the basic treatments that you can go through. I won't go through them, belabor them in detail, but they're usually very straightforward. And how you treat based on what you find. So basically, when you're going through your ACLS protocol, your goal is not just to get ROSC. Your goal is, as you're working to get ROSC, you are trying to figure out what the cause of their presentation is. So you go through your H's and T's, right? You look for trauma, you look for stuff like hypoglycemia, hyperglycemia. And so H's and T's are also on that ACLS protocol. I won't go through that in detail, but H's and T's are important stuff to remember. And then I don't know if you guys need to go through ABGs.
Yeah, so this is just a slide I include because I'd had it made before, so it's quite complicated, but it's an approach to ABG, so I won't go through it in detail today. Basically, the main things is like, how do I recognize an alkalosis versus an acidosis? How do I recognize respiratory versus metabolic? And then understanding what a gap means. So really, it's like, how do I do a gap? What is the differential for a gap, like mud piles? Those are really the big things. Like in terms of like figuring out, is this compensated or not? You probably won't need to do that on the test, but you will need to interpret things to make sure that it makes sense with the situation. So the ABG on this test or on this case, if you go back and look at it, I'll just go quickly back. You can see that they're very acidotic. Their CO2 is being controlled by their bag valve mask ventilation. So it's not as helpful here, but it's essentially normal. You know, it's a little bit lower than normal, but we'll talk about that in a sec. And then the oxygen looks okay. So you're giving them adequate oxygen. And then they clearly have low bicarb. So they have an acidotic problem going on. And then we're compensating with that appropriately based on the PCO2 of this. And then you can see that they have a huge gap. And part of that is due to lactic acidosis, which is due to their shock. So yeah, it's just important to be able to recognize that this makes sense with the clinical scenario as opposed to doing like the true sort of internal medicine nitty gritty, going through and figuring out all the details of it. Okay, yeah, let us know if you guys have any questions. Case 10, I'll give you guys 90 seconds.
Okay, so we've got a 17-year-old girl with episodes of heart racing and lightheadedness, and they're episodic and occurred many times over the last 2 months. So this is something that's relatively new for her. And they start with her feeling anxious and her heart is racing and she has trouble breathing with paresthesias. So kind of there's some things kind of making you think towards your differential there. And the symptoms reach their peak within a few minutes, which is very characteristic of what we call panic attacks. And they resolve spontaneously within 1 hour. And she exercises without problem, but she worries about her symptoms recurring. She's got a history of ADHD and she's on methylphenidate. She lives with her parents and she's struggling basically at a new school. So our differential is anxiety or panic attack. And then the other one to kind of think about is cardiac arrhythmia. She is on a stimulant, methylphenidate. So next slide, Paul. Anxiety disorder. So what are we looking at here? So commonly, you know, women and stressors in life will predispose you to this, and how do we treat it? It's a multidisciplinary thing. I don't know what you guys were taught, but typically it's the three-pronged approach, right? You look at medication, you look at counseling and CBT and working on coping skills, and you work on lifestyle modifications, so things like exercise, diet, maintaining a regular schedule, etc. And then the things that might come up on the test, so safety concerns, like whether or not you need to form someone, And those are the common ones, right? Obviously, if they're actively suicidal, if there's homicidality, and if there's risk of harm to self. And then the other one too is to keep in mind if there's minors involved, and then that might also be a safety concern for you. And then there's obviously, we look at the biopsychosocial stuff. So like we're talking about the three-pronged approach. And then because she had palpitations, the differential for her widens a little bit, right? Because you're not just looking at anxiety and panic attack, but you also want to make sure that there's nothing cardiac, potentially endocrine going on, or stimulants or substance use. So those are some of the examples of investigations that you can order if you're kind of thinking down the pathway of a variety of different differentials. And then the green highlighted stuff are treatment things to kind of review and make sure you don't forget about on the exam to kind of go over. Yeah, and I think it might be dependent. So if you get an ECG and they ask you to identify the ECG and it's clearly arrhythmic, you cannot write arrhythmia. That will not be the right answer. You need to give them, if they're asking you what specific rhythm it is, but in a case like this, cardiac arrhythmia, I think might be okay as an answer there. And then next slide, Paul, unless you wanted to add anything to this slide.
I'm just typing a few things in the chat just so you guys know, but yeah, nailed it, Amanda. So we'll do the next. Yeah, perfect. Well.
Okay.
So as you guys are doing this too, yeah, just with the arrhythmia question as well, just like my 2 cents, my general approach, just broadly applied, is like be as specific as you can. So if you're worried about arrhythmia, but you're like, I have no idea what arrhythmia is, write arrhythmia. But if you're like, this is AFib, 100%, write AFib, right? If this is an SVT, but I don't know which one, right? SVT, right? So just be as specific as you can, because it is marked, especially write-in ones are marked by humans, so they may give you points. Yeah.
Is that time yet? Because we're getting answers trickling in.
Yeah, this one's pretty straightforward. So let you guys know the answer now. So, you know, you're going to see back pain, and back pain's a good differential to go through because it just has like a broad differential with some very distinct features, and that's what the red flags are based on. So when you think about the most common thing you'll see is just like a structural MSK sprain and tear, but a red flag of that is it not improving after 6 weeks, if it stays consistent or worsens after 6 weeks. And then, you know, you just got to know some conservative therapy options that you can write down. I think we have some more info on this later, so we'll talk about it a bit more later. You know, degenerative disc disease with radiculopathy, that's a common presentation that you're going to see. Remember, this is usually a middle-aged person because they have enough of that jelly in the middle of their disc, where if it pops out from the annulus, which is the fibrous in the middle, and there's the jelly. I can't remember the name of it right now, but it pops out. So if you're old, that jelly is basically gone. It's just dried up. Anyways, that's what someone told me one time. But if you're middle-aged and you have a disc disease where that fibrous structure holding in that jelly breaks and it pushes through, you're much more likely to get a nerve that's hit because you just have a larger protrusion. So a middle-aged person with a back injury suddenly, that's much more likely to have radiculopathy.
Paul, the words you're looking for are nucleus pulposus and then the annulus fibrosis, by the way.
Nucleus pulposus. Make sure you guys know that one for the test. I'm just kidding. And then, yeah, so think about the dangerous mechanical things too, though, right? Like, you know, vertebral compression fracture, if they have focal pain, that's like a red flag. Focal spinal pain, that's new. If they have osteoporosis, you have to get a back x-ray because you need to rule out a compression fracture if they have back pain, especially if it's tender focally. So, you know, spinal stenosis, how do you pick that up? The shopping cart sign, like claudication type thing. So it's kind of like a neurogenic claudication, which means that it gets worse with time, over time, similar to a vascular claudication, which gets worse with exertion. over time. Usually neurogenic claudication is more positional. So it's either like walking or sitting or standing for too long. And then you got to think of the inflammatory conditions, right? You got to think of the infectious conditions. This one was a classic red flags for epidural abscess and infectious conditions. You got to think about neoplasm, right? Think about primary neoplasm, like primary bone cancers or multiple myeloma. Think about metastases and the common ones there. I think kidney is incorrect, honestly. I meant to change that, sorry. And anyways, here's a bit of a review slide that you can go through on your own time as well, just going through the different levels. Like if you see this reflex affected, what dermatomes or spinal levels should you be thinking of in terms of nerve roots? And then really you got to think of a neuropathy differential diagnosis. So these ones, again, they're pretty easy to differentiate clinically. So, but you got to think of what the differential is. So like mechanical, the classics being like carpal tunnel syndrome, and then systemic things, right? These are like syphilis, B12, diabetes, multiple myeloma can cause polyneuropathy, right? So these are things that should be on a differential, and then cranial, and then central nervous system as well. So this is the time when you're thinking of multiple sclerosis and you would do an MRI brain and spine. So this would be the one time for sure where you would choose an MRI over a CT scan for sure. And then think about nerve conduction studies. So nerve conduction studies basically has like these red flags for neuropathy, which is if there's a motor component, because usually, let's say like with carpal tunnel, classically sensory is affected first. And then if it's become severe enough or it's there long-term enough, it'll become motor. And then that's usually an indication to get nerve conduction studies, see where you're at and consider, stepping up therapy to get resolution of the compression. And then also just if it's like a really complex neuropathy and you're not sure what's going on, then nerve conduction studies can be considered for sure as well. Like any new progressive, dangerous seeming neuropathy, NYD, should be had of a nerve conduction study. And then also any red flags of like motor involvement. Could you have osteomyelitis? You totally could have osteomyelitis. It's good. It's not usually in the back though. So it's not a big one that you should think of, but you're thinking of the right things. Sure. Okay, so I think let's keep moving here. So case number 12, I could guess 90 seconds. Let me know if you have any questions about back pain. I think you guys have probably seen that one a lot.
Okay, we're getting some answers, so we'll just get into it. 28-year-old female presents to emerge with abdominal pain that's worsening. So she's got some looser stools, up to 5 bowel movements a day during that time. Pain worsens with defecation, no infectious symptoms, no sick contacts, she's had constipation in the past, and intermittent abdo pain. And appetite is fine, little nauseous, not vomiting, and vitals are fine. So also diffusely tended in the lower quadrants, but not peritonitic. So you're thinking, hey, this is acute on chronic kind of abdo pain with diarrhea. There's no really red flags for her. So you're thinking more along the IBS picture, but this is an important question that it comes up on the test, not necessarily in this fashion, but things that you think about that you cannot miss. And the answer is the beta, because this is something that you don't want to miss. So what investigations would you order for this patient? The beta is the one that's going to be on there. Yeah, so abdo pain, very wide differential, especially with or without diarrhea. If you look acutely, infection versus other causes. So if it's a viral like gastroenteritis, you treat supportively with fluids. If it's bacterial, you look at obviously what the cause is. And some things will suggest different bugs versus others. So if they had recent antibiotics or recent hospital stay, C. diff is the one that you want to be thinking about. Vanco, and if it's bloody, obviously there's that mnemonic that you can use to look for bloody bacteria in the stool, and you can use stool culture and O&P investigations for somebody who's got bacteria, or what you're suspecting is bacterial or parasitic infection. And then colonic ischemia is another one, and then toxins and meds like metformin can cause diarrhea too. So chronic is anything over 4 weeks. And so there's a couple of different categories, like we've broken it down for you. And the different types are osmotic secretary motility, and IBS is the big one that we see commonly in the office, and the Rome criteria is something good that might be to review for categorizing IBS. And IBS can be diarrhea predominant, constipation predominant, or it could be a mixed picture. And the one thing that we had in our question that was a bit of a kind of a misdirection almost is that the pain gets worse with defecation. Typically pain gets better with defecation in IBS, but every so often you can have the reverse. And then we also have large bowel and small bowel causes on there. And treatment for IBS is we look at the FODMAP diet, we look at fiber. And for diarrhea predominant IBS, you can think about using antibiotics like rifaximin if you need to help. And then constipation predominant IBS, you could treat with Constella. And so those are our answers up there too. And then Paul made a really fancy diagram on the right-hand side, basically looking at how much water you take in and where that water gets absorbed, because some people only think about like the large intestine, but if you look at the small intestine, there's a lot of absorption. Yeah. I don't know what you wanted to talk about for oral lesions there.
Just basically be aware that oral lesions may be asked about. I think they're pretty simple and they're pretty easy to recognize. But have a differential for oral lesions just so that you can have a few things to put and a few things to consider on those questions, because it's not often covered, but something to think about, right? You can get like inflammatory lesions like Crohn's, you can get infectious lesions, like implanus is not an ulceration, but has a different appearance in the mouth. And then tumors as well, like head and neck cancers, right? Those red flags that every cancer will have will be the ones that they use to describe head and neck cancers and tumors as well. And then think about sexual abuse as well, especially with like STIs in the mouth, children who have oral lesions that aren't explainable. So anything else that we'd be thinking about that would commonly have increased pain after defecation? No, it's non-specific, but it is specific to IBS. So it increases your probability of IBS. How much does it do that? Probably not much, honestly, but a little bit. But it doesn't, it kind of just helps in the IBS category, but doesn't rule out anything.
And then just one more thing about the beta. On the exam, they might lead you more in the direction of the beta, but anytime you get a reproductive age woman who's presenting with pelvic or abdominal complaints, always think about the beta, but for them, they might say, hey, she hasn't had her period, or it might be a little bit more specific to lead you down the beta path, or it might be just as vague as the question that we gave you, but it was a very vague question. So it's fair that you would have thought about other things, but the beta is the do not miss. Okay, case 13 for Paul here.
All right, so we'll give you guys 30 seconds to start going through it. So IBD does not specifically cause pain associated with defecation. It's more prominent that people who have IBS will complain about pain changing, either getting worse or better with defecation. But other people who don't have any bowel diseases can also complain of that. So it's just one small piece of clinical data. But when they say it, it's a bit of a buzzword because it's more common in IBS. So it should make you think about IBS when they say pain changes with defecation.
Yeah, and that's part of the Rome criteria for IBS, right? The pain improves with defecation.
That's right.
That's the classic finding for IBS.
Yeah, I'm seeing some good answers here. So Basically, this is someone who presents with dysuria, right? So this is a differential for dysuria, and it's a male, which changes things. And you guys are kind of getting, you're catching on to that. So specifically what this patient requires is a digital rectal exam to feel their prostate. They are query prostatitis. That's this working diagnosis for this question. And so you want to feel the prostate. Why could they have? So what you can do is you can have a very tender, boggy prostate, which confirms the diagnosis. They also might have prostatitis secondary to a prostate cancer. It's totally possible. They must have like a huge abscess on their prostate that you'll feel when you touch there. So it's part of the assessment. And then you need to do a urine culture, right? Because you need to isolate the bacteria that might be causing this infection, and you can get it from the culture every so often. And then you need to do gonorrhea and chlamydia, because specifically an infection that can cause this is gonorrhea and chlamydia, sorry. So those ones you need to do. Do you need to do urinalysis? You don't need to do it really, but it's not a wrong answer. So you could have included it in there. Could you have done a CBC based on how sick he was feeling? And that totally reasonable, but those three to make the diagnosis and do proper treatment and proper assessment are the things that you need to do. So we'll talk about dysuria just a little bit here. So this is again one of these things where it's like common benign versus rare and serious. And we used to always think that the common benign cystitis, bladder infection, and the rare and serious kidney infection, pyelonephritis, were connected along a spectrum, but really they probably aren't. People just get a bug that either causes a bladder infection, cystitis, or they get a bug that causes a kidney infection, pyelonephritis, and their immune system plays a role in that as well, of course. So what are the cardinal features of someone who has a bladder infection, cystitis? So this is a healthy young female, comes into the clinic complaining of dysuria and potentially some other related symptoms or related findings that you can see clinically, like urinalysis. So like lots of times in the family medicine clinic, reading these case stems, you already have a urinalysis that tells you a little bit of information. So it's kind of like part of the assessment, initial assessment. Know the common bugs and the common treatments. Know, a couple extra details around that. Basically, I would just know the acute treatments. And that, prophylactic antibiotics is an option, and, you have to make some considerations around recurrent UTIs, but I wouldn't really go into the nitty-gritty details around there. And then definitely things that should make you think of something else is if you have these other features, so like mimic. So if they're male, you have to definitely rule out prostatitis. That's number one. If they're, and an STI, of course. If they're peds, right, you have to consider imaging and an ultrasound for vesicular reflux. If they don't have dysuria and only lower urinary tract symptoms like frequency, urgency, incontinence, then you're thinking of primary bladder issues like overactive bladder and non-infectious things. If they only have dysuria, you're thinking of, and they don't have any lower urinary tract symptoms and bladder symptoms, then you're thinking of just like topical things like atrophic vaginitis, which commonly happens in menopause and can be treated with topical estrogen. And then if you see discharge, so not just dysuria, but abnormal discharge, that's when you're thinking of not a urinary tract infection, but a genital tract infection. So remember, in males, they share their genital tract infections. So they share a lot of the symptoms, right? Their genital tract is the same as their urinary tract. In females, they're actually distinct, they're separate. So usually you can separate those symptoms. So when a female comes in with dysuria, the best next question to ask them is, do you have a rash? Right, a vaginal rash, or do you have vaginal discharge? If they say yes to that, you're thinking vulvovaginitis or STI, and that should be your workup and your treatment. Okay, also just beware if you treat someone with a UTI after with antibiotics, you may also induce candidal vulvovaginitis. So if they come back to you a week later and they say, oh, I'm still having some lower urinary tract symptoms, but now they have a little bit more like just general irritation or a rash and some discharge, you've caused candidal vulvovaginitis. You need to treat it with an antifungal. I've done this many times and I've also missed it a couple times. So beware of that. And then recognize pyelonephritis. This is cystitis plus other features. So these are the red flags on exam that you'll look for. Flank pain. Are they febrile? Are they unwell, right? Do they have a high heart rate? Do they seem shocky? They just feeling really, really unwell, like puking, laying in bed, fatigued, muscle aches and pains. And that requires more intensive treatment because it can be dangerous because it can lead to things like urosepsis and mortality and morbidity. Should we have listed a genital exam for physical exam? It's not unreasonable to do a genital exam. At the very least, do like a cursory observational one to look for lesions on the skin, but you wouldn't have to do, say, like a testicular exam because he's not really complaining about testicle pain. He's complaining about dysuria. So you're more so thinking urinary tract, genital tract infection as opposed to a primary testicular issue in this case. But good thought, for sure, definitely could be right answers in these types of cases. All right. Let's go to the next case here.
Next case.
Also, just the imaging question, it would be reasonable to do imaging for this patient, but what are you trying to answer by doing imaging? You're basically trying to answer, do they have a structural abnormality, or do they have reflux that's causing them to have stasis and predispose them to infection? This patient may just have gonococcal prostatitis. So if you confirm that, you don't need to do any imaging, because people who have normal anatomy and don't have reflux get gonococcal prostatitis. So it is a reasonable thought, but where you are in that situation, in the context of the last case, you don't need to do any imaging. It wouldn't be warranted or indicated yet. If gonococcal infection was ruled out, then maybe you would.
Yeah, but he's also a young, healthy male with his, like, presumably it doesn't say he's had recurrent UTI. So if he was an older guy, had a lot of medical comorbidities, or this is already not his first UTI, you would definitely look at imaging right away. But otherwise, if they respond adequately and it's a bacterial like cystitis, it's fine to not image right away unless it comes back, and then either sending to urology for a scope or doing a CT would be your gold standard, would be okay. All right. So case 14 here. So you've got generalized pruritus with rash, and she has a history of allergic rhinitis and lupus. And on exam, you see, and we tried to use the keywords here for excoriations, and that's something important to be able to recognize on your arm, on your exam. So those grouped linear erosions with scabs where you're scratching. So for her, it was her torso. That's something to pick up, that those are excoriation marks. And so in terms of what investigations would you consider next, we asked you to select up to 3. Paul, if you could hit next for us. And so what do we want to make sure it's not? So with generalized pruritus, you want to make sure that there's nothing biliary or in the liver that's doing this. So liver function testing would be very reasonable, as well as a CBC and a creatinine, given her lupus history. And Paul, I don't know if you wanted to add anything else to this one in terms of.
Yeah, I don't think so. You know, mainly you're generally gonna clinically diagnose pruritus, and most commonly it'll be a rash associated pruritus. But you have to think of the differential, especially with this person who has like medications and medical comorbidity.
Exactly. So if we go to the next slide, this is the differential for pruritus, so rash, infection, and systemic causes. And then so for rash, like we wanted to reiterate, treat with topicals if they're itchy and if they look irritated. And then for allergies, the treatments, you start with oral antihistamines. You can go to oral steroids if you need to. And then there's also newer stuff that's like oral biologics to help try and tamp down that immune response from the IgE. And then for infectious things, there are keywords on the exam. So for example, for scabies, you're gonna look for the burrowing tracts. You're gonna look for the pattern of distribution there. And then systemic things, like we were saying, like for uremia, there are certain findings and investigations, cholestasis, and that's why we wanted to do the investigations in the previous question there. And then Paul just made another photo here for the different types of immune responses, right? The different classes. And remember that anaphylaxis falls under the immediate class 1. I don't know how much you want to explain this, Paul, but it's very straightforward. The different classes of hypersensitivity.
Basically, what you should be thinking about with hypersensitivities is that there is different types, and they are very easily differentiated. So type number 1 is super fast, right? This is IG, this is anaphylaxis, this is allergic urticaria. And so these are like these quick hitting ones, like with anaphylaxis. And then the delayed T cell ones, these are delayed ones that are caused by a different trigger, right? Like drug reactions that are delayed, like a contact dermatitis, like getting poison ivy on you. It starts happening right away, but for days and days. And contact dermatitis is a little bit different than other dermatitis in that you'll get like vesicles and bullous and stuff. So that's how you kind of pick those out as opposed to just like a atopic or an allergic dermatitis. So just knowing like there is difference between these things. So really the big thing is like, what is the trigger? What is the timeline? And what are the basically like the clinical features and characteristics? And that'll help you differentiate and help with the diagnosis. Yeah, I agree with what you guys are saying here. Basically, everything is diagnosis driven. So for the differential, it's cholestasis. So liver enzymes don't tell you if someone's cholestatic or not, but the liver function test will. And those are an accepted response. You don't have to say Billy specifically. You can just say liver function test or liver enzymes as a response is right in. All right. So we just have 3 more cases. So let's do this case now here. And then we're going to just debrief quickly before you guys for 5 minutes for any final questions and just get your guys' thoughts on how we thought things went. But we have a few more cases here. We should be able to finish by 10:20, 10:25 at the latest. Right, so I think you guys gave you enough time here to go through this one. So this is a male brought to the emergency. He's got a traumatic ankle injury, right? So really this is asking you, how do you interpret his injuries and what are the next management steps? And you can use the Ottawa ankle and foot rules to help guide you. And anyone who has a traumatic injury, no matter what the diagnosis is, you can safely do rice to help alleviate their symptoms, right? And these other things could be dangerous, like he can't weight bear himself, which is an indication for an x-ray. And why do we do that? Because we're worried about a fracture, and people shouldn't be walking on a fracture, especially when we don't know what type of fracture it could be, right? This is actually kind of getting at a Liz Frank injury. So a Liz Frank fracture is a cannot miss ankle injury, which is often missed by a distracting ankle sprain, like a classic ATFL sprain. Methotrexate can have liver toxicity, right? Yeah, but is this patient presenting with liver toxicity? No, they're presenting with an ankle injury. So sometimes these things can be more distractors than others. Like the previous case, like I was explaining with the lupus, I'm not trying to get at like, what are the complications of lupus and what are the symptoms of lupus? It was just, I gave them a random diagnosis to say that they're not previously healthy. That was the point of it. So you kind of got to try and interpret this within that. So again, that's just a red herring in this case. Oh, I see what you're saying, Kate. So the methotrexate for the previous case, yes, but they were presenting with pruritus. Methotrexate doesn't cause pruritus, so I'm not worried about that medication right now. So you got to try and stay focused on the clinical problem. That's the key clinical problem presented in the case. And again, you work through that topic. Can I confirm this diagnosis? Is it the classic presentation? What are the dangerous differential diagnoses that I might need to rule out with investigations? What are some other investigations that I do to potentially confirm the diagnosis I'm suspicious of? What's the initial management plan, right? What's like the need to do like reporting for this condition? Those are the questions you should be asking yourself. Okay, we got a little sidetracked there, I feel like. Okay, so Msk Pain, it's good to go through a differential. Again, you'll recognize that this is like kind of a similar organization as the back pain, right? So you have like mechanical stuff. And again, this is very specific features, right? So like trauma, right? They'll have like pain with movement. There'll be pain kind of diffusely around a joint. They may have some associated inflammation, but it should be minor. You should always, when there's trauma, do a peripheral neurovascular exam to rule out red flags of, ischemia. And then there's just the different features of the infectious things that you should think of. With kids, when they have focal bony tenderness, you're really thinking of a primary bone cancer versus osteomyelitis, and you need to rule those things out with an x-ray of that area of the bone. The malignancy red flags here, right? You guys know those ones well, I'm sure. The inflammatory conditions that you should think of, including crystals. So whenever you see a new hot joint that maybe could be crystals, right? The classic ones being like the first MTP of the foot, the ankle. So those are the common gout ones. You should aspirate that. And on your differential is a septic joint and infection, which is another, very dangerous but rare thing that you need to rule out. So new red hot joint, you get the cells, which can help differentiate, is this inflammatory versus infectious versus not either of those things. So the cells is like the white blood cells. You get a culture and stain for infection, and you get the crystals, right? So a little bit about like bifidrins and how to recognize how the crystals look on there. And then there's some treatment options for gout that you guys will need to know. And then the derm stuff as well, right? Dermatomyositis is a red flag for derm, for muscle pain. And then there's functional stuff like fibromyalgia. These MSK treatments are just things that you can put as options for management when you're not sure, but it's an MSK injury. So it's just kind of a cheat sheet. And then the most helpful things is that you should ask yourself whenever they're presenting with pain, and it's like an MSK pain, is it articular versus non-articular? Because if it's articular, it rules out all the non-articular things and vice versa. So that's a big key differentiator that can make you not go astray. And then the distribution as well, right? Like if it's small joint, if it's symmetrical multi-joint, that's inflammatory. If it's a single isolated joint, that's like your classic differential. Like, is this trauma? Is this osteoarthritis flare? Is this a septic joint? Is this a crystal arthropathy, right? And then really the natural history. So this first graph shows basically what a septic joint would look like. So it's massive, progressive, acute, accelerating pain with constitutional symptoms, not usually fever, but they just feel crappy, and pain out of proportion. They can't walk on the joint. They can't let you move the joint wherever it is. So those are the things. And then this fluctuating one, which might happen over years, is say like osteoarthritis that goes up and down over years, right? So the pattern is really the most basic thing, or most important thing, I should say. All right, this is the second last case. Let's do it. So Michael just had a good question, like when they ask for investigations, can you put physical exams? They won't typically do that. If they're asking for investigations, they want imaging or blood work or other investigations, like, like a swab, whatever it is, where you send it to the lab or you get a report back. But when they say management, when they say, how do you manage this patient? That may include doing certain physical exams or even certain history questions to rule out red flags. So that could totally be included. But usually they're being pretty specific. So read the question carefully. And if they specify investigations, that's usually what they want.
Yeah, or if they say what imaging, make sure you're only ordering imaging. And if they say what blood work, make sure you're only ordering blood work. Sometimes people get caught up and tripped on those. Okay, case number 16. A guy presents with what sounds like Parkinson's symptoms, right? He's got a tremor in that left hand, changes to his writing, so micrographia, facial expression, masked faces. You get that orthostatic hypotension with the lightheadedness and the falling, family history of the tremor, and the beer that does not improve his tremor, makes you think less likely of an essential tremor. He takes ketamine at night, and then obviously the big ones, cog-wheeling rigidity and abnormal gait, part of your trap mnemonic for Parkinson's. And what investigations would you order next? For Parkinson's, it's a clinical diagnosis. So the answer is none. And the autofill is CT head because we don't want you over imaging. And then if we go over Parkinson's, obviously there's primary versus secondary. So secondary can be elicited by antipsychotics. And we went through that trap mnemonic there. And so the tremor, pill rolling, asymmetric, 4 to 6 hertz. The rigidity, it could be cogwheeling or it could be lead pipe rigidity, and you get akinesia or bradykinesia. So, and then the last one is the postural instability. So you get the gait abnormalities there. And then there's a lot of other associated features of Parkinson's. So TRAP is your classic pathognomonic presentation of Parkinson's, but oftentimes you'll only get some of the findings. Tremor most typically presents with the Parkinson's, but like we said, you can get the micrographia, the face views, the anosmia, and the hypophonia. And then you look at Parkinson's plus, right? So if you've got neurodeficits, you're thinking about things like PSP, and then you can think about dementia, Lewy body. And then the treatment is levodopa, carbidopa, or cinnamon. And then there's the differential on the right-hand side that we wrote down for your tremor. So secondary primary causes of hyperkinetic tremors, and you can get dystonic tremors, and then Parkinson's falls under the bradykinetic tremors. The common one that you would see, like we would see in the office, is the essential tremor. So know that it gets enhanced with certain actions, it gets better with alcohol, worse with anxiety, and if it's very severe, you can get resting tremor.
Yeah, awesome. So
oh, there's a question.
Move to the next case here. So yes, these questions here. Yeah, so sometimes you'll put none. Sometimes that'll be the answer. So when that commonly is the case is when it's a clinical diagnosis. So what are some very common clinical diagnoses that you guys know? Migraines, right? That's a clinical diagnosis, 543210 sultans. If you can say that they have 543210 sultans, don't need to do any other further investigations. What else is a clinical diagnosis? Like technically, like, you know, like some of these things like appendicitis is like a clinical diagnosis, right? Like technically, but we often confirm with imaging. So it's kind of a tough one. Even than what we did before, like pruritus or like hives or rashes are a really common clinical diagnosis. Like if it has the classic description, it responds to like treatment like that we commonly do, like topical steroids. Like it's just clinical, you don't need further investigation. So in that previous case, that the itchy one, if they were itchy and they had hives, you saw a rash, and they didn't have any medical comorbidity and they had no other signs or symptoms, you would say, you have urticaria. I don't need to do any investigations on you actually. And you would just treat them as urticarial rash with antihistamines or PO steroids. Okay, we'll give you guys a couple of minutes to go through this one, and then we'll have a chance just to talk about this case a little bit, and then we'll do a 5 to 10 minute debrief. I know that you guys have a session at 10:30, so we won't go past that for sure. It's nice to get a little bit of break, but we'll just do a little bit of a debrief just to kind of talk about a few things quickly at the end. Okay, so we have an Msk pain. So we just went through the differential. So this is fibromyalgia. So this is about understanding how to recognize fibromyalgia and what additional tests may be needed in the workup. So for them, they have muscle pain. So you do a CK. They also, you want to rule out an inflammatory condition, right? Like polymyalgia rheumatica. So a CRP is super sensitive to rule that out. Yeah, you want to make sure that they just don't have any general sort of medical illness that's causing their severe fatigue, right? So a thyroid is a common thing where it may manifest with just non-specific symptoms and nothing specific. For sure, you would do a TSH if they start giving you clues about thyroid problems as well, like hair changes or like, you know, temperature instability, etc. And then the CBC as well, make sure they're not anemic. So really you want to do less is more, right? So you're not too suspicious that this is rheumatoid arthritis. So why would you do an anti-CCP or an RF, right? If you're thinking query rheumatoid arthritis, you should do that. But what we're in right now is this seems like fibromyalgia. So as part of the fibromyalgia management, we're just doing some investigations to rule out some of those things, some of those other things. So you will need to recognize fibromyalgia as in the objectives. So this is commonly a middle-aged female. It's a chronic pain syndrome. There's 3 clinical features: widespread muscular pain with tender points, right? Doesn't really matter what the distribution is. They'll complain about many different characteristics of the pain. It doesn't matter. It's just widespread pain that's tender. They have a sleep disturbance that causes fatigue. It might be trouble sleeping, or it might just be that they sleep and it's non-restorative. And then they have lots of psych or mood symptoms, so depression symptoms. Just think of MCV caps. They'll have lots of them. And there's no other explanation, right? So there's a bit of a workup, as few as is needed, to make you confident that there's not some other explanation that hasn't been investigated. And then the treatment is mostly lifestyle, biopsychosocial. There is some medications, but they're not as effective. So amitriptyline and some of the other common chronic pain medications can be used. Now, what's interesting is there's lots, these patients, like how you diagnose it is the symptom severity score, and it's like the widespread symptom scale, which basically lists every symptom a human can experience from head to toe. And most of these patients will pick off like at least 50% of them or more. So oftentimes they get co-diagnosed, or that they're suspicious of having things like migraines, chronic fatigue syndrome, chronic Lyme disease, etc. They get these other labels as well, and you have to manage them. Just a quick note on a Lyme disease, it might show up. So know the classic erythema migrans and the treatments of doxycycline. And then you also have to recognize some other complex pain or chronic pain syndromes, like complex regional pain syndrome. Really what this is, I had a case of this recently. This guy had a hip surgery on his right hip. And then about 2 weeks after the surgery, he started having excruciating, searing pain in his right foot. And it's like swelled up, it changed colors. It felt like it was different temperatures, and it was extreme. It lasted for months. And it had no other explanation. And so that's complex regional pain syndrome. That's pretty classic. So it's those neuropathic pain. It's usually quite severe. And it's those physical changes that you can actually see. And this is like dysregulation of like the vascular system, the neurological system in that area. It's idiopathic. We don't know why it happens. And then don't forget about some basic things about painkillers, and like when you can think about certain adjuncts and when they may be indicated and why they're helpful. Some basic stuff around Tylenol and Advil that you have to know, like pediatric dosing might be reasonable to know, but knowing the common side effects and contraindications for these common medications, you should basically think of these pain meds as just like a messy, muddy swamp, and you just have to navigate it as best you can, because even sometimes the simple stuff can cause damage, and sometimes even the stuff that's avoided is indicated based on specific features. Okay, so thanks so much for listening. So why don't we just start a quick debrief? You guys can put in just any comments or thoughts, final questions in the chat. You feel free to speak up. I want to reiterate one thing. We just went through 17 CDM style cases. We purposely picked what would be the hardest 10%, we think. So you can believe us or not, but you should not feel as though you did well. You should feel as though you've recognized learning gaps and you've learned some strategies of how to answer really hard questions when you're not sure of what the answer may be. Because you're going to get 75% of the questions on the CDM is going to be like, I know exactly what this is, if you're well prepared. So this is just a guide to help you kind of focus, so you don't have to like learn everything about Parkinson's, but you should know like, how do I differentiate primary versus secondary? What is like the core features? What are some complications that might come along with it, so that I can recognize them and not get confused, right? Because if someone comes with Parkinson's, like our case here, and then they have postural changes in their blood pressure, you don't know that that's a feature. You'd be like, something else is going on, and it may send you down a different topic or a different path in your mind. So yeah, I want to reassure you guys that, you shouldn't feel like you did well or like you passed or anything. This was a learning exercise that we did. And these CDM questions are a unique beast. You have to practice them to get good at them and to understand them and to build simple strategies to make it so that you get them right more often. So today was just the first step. But I'm glad that you've had the practice now doing them, because then it's better than practicing when you go write the real test. So do keep doing practice questions. Go through our practice questions again, our cases, and pick a different question. Be like, instead of being like, what's the management or what's the investigations for fibromyalgia, be like, what's the 3 management things for fibromyalgia that I could put as answers, right? So I hope you guys are feeling like this was helpful for you. Good luck on your test. If you have any specific questions that you think we can be helpful with, please feel free to reach out to us. But we'll have the slides, or you have all the slides available, and you can use those to study and help guide you as you go forward.
Oh, one more thing to address is Sky had a question for the as many as appropriate questions. Basically, they have a secret number in their head, and if you go over that, you will fail the question. So don't go overboard if they say as many as appropriate. Don't like just shotgun approach. Think about what you want to order and why you want to order those tests. Those are the tricky ones because you can risk going too many. If they only wanted 3 and you put in 4 or 5, then you would fail that question.
It's not a secret how many they want, though, like in terms of what will make you fail. Like if they say give 5 answers, you can give 5. You just can't include.
No, but Paul, there's some that are they say select as many as appropriate, and they don't tell you how many you should select. So those are the tricky ones. That's what I was referring to for Sky's question. Yeah.
Thanks, Amanda and Paul. That was great. Lots of information. Just a quick question. Do you have a copy of your slides with the answers marked on them so I can share those with the students after the lecture?
Definitely.
Yeah,
I'll email them to you right now, Shauna. Okay.
Sounds good.
Okay. All right. Well, we'll head off. Again, please feel free to reach out if you guys have any questions or anything. Good luck on your test. You guys are going to do great. And yeah, good luck in the future. Look forward to seeing you guys around.
Yeah, hopefully we get to teach you guys sometimes. Thanks, Shauna.
You're welcome. Thank you.